Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center. Today's medical tutorial is on the Whipple procedure, hepatic arterial anatomy, considerations, and pitfalls. Just for a quick review, type 1 hepatic arterial anatomy. The celiac artery gives off the left gastric splenic artery. Common hepatic, proper hepatic with the gastroduodenal artery takeoff, right and left hepatic artery. This is present in somewhere in the 55 to 70% range, depending on which study and autopsy study you read. There was an excellent study on using 1,000 cadaveric donors for liver transplantation by Dr. Hyatt and Dr. Busatil out of UCLA, where they looked at the donor arterial anatomy in 1,000 transplants. So some of this data is from autopsy studies and some from transplant donor data. Nonetheless, as you have learned during the Whipple procedure, the gastroduodenal artery needs to be ligated. One of the pitfalls that can happen, regardless of the type of anatomy, is if there is a, this is the celiac artery right here, by the way. If there is a high-grade stenosis of the celiac artery and hepatic artery flow is in this direction, ligation of the gastroduodenal artery, which is required during the Whipple surgery, can cause a decrease in flow in the proper hepatic artery, or even thrombosis, leading to hepatic necrosis. So it's routine to perform a quick test clamp, either with a vessel loop or just with a bulldog clamp, and to check the pulsation. Celiac artery stenosis is more frequently identified on preoperative imaging because CT scans with the arterial phase contrast more frequently will pick this up. There are cases where this high-grade stenosis can be stented preoperatively if it is identified preoperatively. If it is unrecognized and there is lack of flow in the hepatic artery, then hepatic artery reconstruction would need to be performed at the time of Whipple surgery. This is pretty unusual, but all it takes is one case where there is hepatic artery necrosis, for which there's no reason to miss that. This is a situation with actually type 3 hepatic arterial anatomy, and we like to actually document that in the operative note the type of hepatic arterial anatomy that's present. I think that's important for the surgeon to actually recognize if there's type 1, type 2, type 3. Type 2 is we're not going to talk about. That's when there's a replaced left hepatic artery off of the left gastric. There aren't truly any Whipple procedure considerations with type 2. Type 3 hepatic anatomy is when the right hepatic artery comes off of the superior mesenteric artery. It travels under the common bile duct, and the best way to determine whether there is type 3 hepatic arterial anatomy is truly just to put your finger under the common bile duct and feel for pulsation. There should not be consistent pulsation under the common bile duct along its entire length. Sometimes you'll feel pulsation if a normal right hepatic artery goes under the common bile duct, which it does in 60% of cases. So careful palpation along the length of the common bile duct and common hepatic duct will help you to determine whether there is a replaced right hepatic artery. Now, a true replaced is present in about 10%, and an accessory right hepatic is present in about 7%, so the total ends up being about 17% of patients will have some type of either replaced or accessory hepatic artery. If it's an accessory artery, clearly it can be ligated, but if it's the best way to tell is just by the size in comparison to the other vessels, or by further dissection. If this is a true large vessel and it has to be sacrificed because of cancer, then reconstruction may or may not be necessary depending on the size of the left hepatic artery. Sometimes I'll just check the back bleeding. If there's arterial pulsatile back bleeding, I won't reconstruct it. If there isn't, it may need to be reconstructed. The best thing to do is to try to preserve it, however. And that means careful dissection of the replaced right hepatic artery all the way to the SMA. And this can be done in both directions. During the SMA dissection, when we look for the pancreaticoduodenal vessels, you just keep following north. We like to do the SMA artery first approach in the majority of our cases recently, and that allows us to actually identify the origin of the replaced right hepatic artery. Type 4 hepatic arterial anatomy is a replaced left and a replaced right, so the replaced right is the main consideration. The complete common hepatic artery off of the SMA is seen in about 2.5%, and that's type 5 hepatic arterial anatomy. If you do high volume Whipple surgery, as we do at St. Joseph Medical Center, you will encounter this a few times a year. So you know, this is consistent, and we find this number to be consistent with with our this number is consistent with our volume to see this a few times a year. It's very easy to spot initially because the portal vein is completely anterior when you're doing the portal dissection. So anterior portal vein is seen and almost immediately identified. And then when you look at the celiac artery and the splenic artery, there's just nothing else behind it. There is a large pulsation behind the common duct. So if this is the SMA, the whole celiac will come off the first portion of the SMA, travel under the common bile duct, and then supply the right and left hepatic artery. Clearly, this is a situation where it could be quite devastating to injure this vessel. If it has to be sacrificed because of cancer considerations, then this is a situation where a saphenous vein bypass is clearly necessary. We tend to like to perform the bypass off the supraceliac aorta. Occasionally, however, though, I have actually reconstructed with saphenous vein off of the SMA itself. If the SMA is of good quality, it serves as a nice inflow vessel. These hepatic arterial anatomy considerations are extremely important to avoid complications of hepatic infarction. I thank you for listening. Stay tuned for more medical tutorials on the Whipple procedure.